Hey everyone, welcome to another episode of Fertility Docs Uncensored. I am one of your hosts, Dr. Carrie Bedient from the Fertility Center of Las Vegas, and I am joined by Dr. Abby Eblen from Nashville Fertility Center
Hey, everybody.
and Dr. Susan Hudson from Texas Fertility Center.
Hello.
And then today, my fabulously, sensationally stellar co-hosts and I are also joined by Rhianne Christopherson. Did I say that right? I should have checked that before we started, but I know that the Rhianne is correct, but Christopherson, and you are a solo practitioner, solo nurse practitioner in Alaska with really the only fertility practice in the state, it sounds like.
Yeah, thanks for having me. I'm looking forward to it.
Well, we are very excited to have you. You work in a very different world than all three of
Yeah.
us. I mean, even as remote as some of our patients are coming from, it's got nothing on rural Alaska. How do you make that work for your patients who are not near Anchorage or Fairbanks or some of the bigger places?
Yeah, it's a great question. And I think a big part of why I went into solo practice was access to care. I've worked in OBGYN clinics, I've worked in women's health, I've done military medicine, and I was just seeing
Oh,
so many individuals lost in that traditional OB-GYN environment and military medicine when it came to fertility care. And there are myths that, in the state of Alaska that you can't get healthcare or you can't get fertility care if you live in rural Alaska. So when I opened, a big part of my practice is access to care. And that means having the opportunity to have telemedicine visits. And so we do a lot of like rural health via telemedicine.
hmm.
Medications can be mailed. Lab tests can also be mailed. We have so much access now that, clients can be sent, a little kit to do their, day 3 labs.
Oh,
Um,
really?
you
Huh.
know, yeah.
We do
And then,
that all the time.
Really? Huh.
Mhm.
Okay.
Yeah. And, and sometimes just working with some of the other. Oh, great. I'm so looking forward to the edited version. Um, but again, like I really pride myself in access to care. I have clients, one of the first things I do in my initial consultation is, my business phone is actually my personal phone. And
Mhm.
so when somebody, leaves the office and their cycle starts, they're getting in touch with me fairly quickly. And then I'm either, getting them set up and managing their, cycle or their next steps myself, or I'm utilizing my nurse to get them set up. And so, a lot of what I have seen is, somebody really just having some barriers to getting the care that they need when it comes to fertility. We all know it's very time sensitive. It doesn't work on a Monday through Friday, 9 to 5 schedule.
No, it doesn't.
Yeah. And, so when it comes to like rural Alaska care, it's tapping into other resources like our mail order pharmacies, specialty pharmacies that can get things out there, kind of just taking larger steps to make sure that care can be given to individuals that, might not be able to make it to Anchorage to see you in person.
So I have a question for you because I don't know the geography of Alaska as well as I should. So how far away is like the patient that's the farthest away from you in Alaska? How many miles or what would the distance be like there? And what
Yes.
would the terrain be like, just out of curiosity, to
Well,
get to
so
you?
I guess I would say, so I'm in like South Central Alaska, and
Uh-huh.
I've had clients that are in Barrow or Ukqiavik is the Inupiaq name, I believe. And that's really far north. I'd have to I
I'm just curious. Yeah, it's
Like
like, uh,
and
like
I'd have to
8
look up
hours.
what miles. You'd have to fly there. So it's off the road system.
oh, wow.
And so you would have to, you'd have to fly there. And, Yeah, Kotzebue is another one that's off the road system that I have clients that we do
Wow.
cycles with.
How
And
do you
we've
how do you deal with doing things like IUIs and IVF cycles and that type of thing when, I mean, I would say probably about 40% of my patients are 3+ hours away from me. So, but I'm also not in the middle of nowhere either place that I am. So it's definitely a different situation. How do you navigate actual treatment? Like I understand how you do like the blood testing and the carrier screening and the semen analyses. Like I get how those things happen. How do you navigate treatment?
So they would fly to Anchorage. So clients fly, they might have a cycle start and then they'll fly down for their follicular study and stay for their insemination.
Oh, wow.
Or if they don't have access to imaging, then they're coming down or coming to the next. Like I have clients that are in Wrangell, Alaska, and their closest hub is Juneau, and Juneau has an imaging department there.
Oh,
So
okay.
we can get some things there, but if they can, majority of the times, if they need to, they want to come to Anchorage and they want, to have the care done in the office because I'm
Mhm.
doing their follicular studies, I'm doing their saline ultrasounds, I'm doing their tubal patency studies. If my nurse isn't in the office, I'm drawing their blood. So it's kind of a one-stop shop
Wow.
in a lot of ways. And to me, that's again just it's the continuity of care is it's a big deal. And when it comes to IVF cycles, I'll have clients where they'll come down for their baseline scan and blood work, and they'll either stay or they'll return home, and come back for their stim. And
Mhm.
sometimes it's talking to the sonographer and the radiologist who's reading it if I'm not doing the scan. And, like saying, hey, can you actually note this report and measure all of the follicles that you're
Don't just tell me there's a lot of follicles there.
Yeah, exactly. I'm like, yeah, great, but can you measure them? I'm pretty decent at, writing on my orders, like, please measure every
Individual
follicle 10
follicles.
millimeters or greater,
Yeah.
measure the endometrial lining, comment, like, it basically like, do you have a crush on me? Yes or no? Check yes.
That's
That's
awesome.
funny.
Yeah.
All right.
Very
Well,
interesting.
we'll talk about a little bit more of those intricacies and how you get some of your tests and how you choose some and what you do and why and all of those things. But let's do a couple of questions first. So Susan, what do you have for us today?
All right. So our questions for today. So our first one is, hi, I love your podcast. It's helped me so much on my fertility journey. We've been trying to conceive for 2.5 years and started with my gyno and did an IUI with some Clomid cycles. No success. Luckily, my husband's company offers Carrot a fertility benefit. We do have to go to a specific fertility clinic for care to be covered. We have done 3 medicated IUI cycles and are in the middle of an IVF cycle. We have seen our doctor in person 2 times and twice online. I requested she did our 3D and final IUI, and she did the egg retrieval. I understand that doctors are busy, but I'm curious, is this normal? Should we expect to have seen her more? We got to sit in with another doctor. He agreed to answer our questions in person. It was so nice to talk and have his time. Thanks so much. I think this is a great question, especially considering we have people from different geographies here.
Mhm. All right. So Abby, let's start with you. What do you think about the number of times she's seen her doc in, in the office versus telemedicine, all of that, and how that's normal?
Well, actually, I think some people prefer telemedicine because they don't have to leave their house. But yeah, it's really tough. I think there's only about 45 doctors a year that are trained to do reproductive endocrinology, and so access to care, which we're going to talk a little bit about in Alaska, is really tough. And I think in our town, specifically in Nashville, our population has really boomed. And I can't really speak to other places, but we basically have the same number of doctors and there's really nobody on the forefront, but we have lots and lots of patients. So we really try and, have as much face-to-face contact with patients as we can, but we also sort of, have patients that have to see a doctor, like ones that are going to do IVF, maybe see doctors and maybe see nurse practitioners first, but we try, as best. I mean, we still don't want to, negatively impact access to care and negatively want to impact the timing that takes people to get in. So kind of our goal is to try and get people in as quickly as we can. And just because you don't have face-to-face time with the doctor doesn't mean you're not getting great care. We have lots of great nurse practitioners and other physician extenders that can really help.
Carrie, what do you do in your practice?
So we do a ton of telemedicine, if no other reason than if you can avoid walking out in the middle of the Las Vegas 110-degree heat. But it allows a lot of our patients, especially who have shift work, hourly jobs, they can take a half an hour break and they don't have to take a full day off of work. And so we do a fair amount of telemedicine. We usually have our initial consult, a follow-up consult. And then when you're coming in, you're seeing, for the most part, the ultrasonographers and the MAs, because for those visits, what you need us for is to interpret those results. You don't need us to draw the blood to do the actual ultrasound. We do have a doc of the day system, which means that each one of us, we try and do our own patients as much as possible, but in order to make sure that we're able to see everybody who needs to be seen and have the level of attention that we can give and the level of specificity and education we can give, all three of the docs in our practice work together. And so it's very likely that you'll see one of my partners. Now, I'm very lucky in that I trust both my partners very
Yeah,
implicitly.
that's important about your practice. You got to have people you trust
Yeah.
and like the way
I
they
mean,
practice medicine. Yeah.
like if I had to have an egg retrieval, I wouldn't think twice about either of my partners doing it. It just would be, oh, of course. And I try and let my patients know that as well, because there's a difference between what they actually need to see me for versus what information I just need to get so I can make the next decision and how that goes. And I try and see people as much as I can, but like Abby said, there is a limit to how many hours in a day, how many people need to be seen, and how we can best treat everybody. And I'm fortunate that I have a really good office staff too, that there's a lot of senior folks who've been there for a while who can explain all of that.
Yeah.
What about you, Susan?
So at Texas Fertility Center, we have a lot. I would say we are kind of more on the excess side on seeing your physician a lot. Now, it may be in person, it may be telemedicine. A lot of that is based on patient preference. Some of our doctors like more in person versus telemedicine. I essentially tell my front desk staff if they want to telemedicine, they want it in person. Either way works for me. It's more considering a good number of my patients come from a long distance away, kind of like Rhianne, that those people really do take more advantage of the telemedicine, and it's great. I mean, because even the two individual people in a couple don't have to be in the same place. But we do tend to do most of our own ultrasounds and IUIs. Now, of course, I have an ultrasonographer at my remote location in Corpus, and so they see Jelaine all the time. But I'm interpreting all the ultrasounds. I see all the images. I'm doing all of those things. And then who does retrievals kind of varies because there again is some balance. And then who you're going to see on weekends and holidays, we all rotate so that we can have a little time away as well. And so I think a lot of it depends on how quickly you've almost gone into treatment, because there's some people who, they come in and they're like, I say, I've had my tubes tied. I want to do IVF. I sit there, I explain to them like all the IVF stuff. And then it's like relatively, we may have a short follow-up visit just to make sure ovarian reserve testing and sperm are as we expect. We don't have hydros or anything like that. And then you're off to the races for your stimulation. Whereas other people who are more sticking their toe in the fertility waters, they're like, okay, well, we're going to do IUIs, and then that isn't successful. And then we have that follow-up visit after that hasn't happened. And so I think some of it has to do with the nature of how much you ask and want to be seen. It is also a factor. Rhianne, what do you experience?
I think it can be really individualized. Some clients, they really want to be seen just in person, and others, it works really well to, do a telemedicine visit. And I can tell right away, just based on somebody's history, maybe they're going to need more in person
Hmm.
for their comfort, because maybe they're coming from a background where they haven't been as supported in their journey, or they're coming from a lot of loss, or have some trauma and anxiety behind it. When it comes to like cycle starts and getting plans going, more people will opt for telemedicine because it's so quick to get
Hmm.
on, with them and go over what their cycle plan is. I'll have, IVF clinics that'll, send orders over, and we'll just right away get people scheduled, based on their STEM calendar. So we're, seeing those individuals in person. So it's a good combination. I do see a lot more people in person than telemedicine. And I think that's just because I also see a high number of individuals here in Anchorage. Our population is fairly small. I think we're still under 400,000 within the
Oh,
city.
okay.
But we're, staying quite busy with, low tech intervention. And, I have a colleague in town that if I needed, if I was going to be out of town, they, could potentially fill in for me if I needed, an IUI. I refer locally to that same colleague for continuity of care for surgical interventions. And then when I'm not here and can't physically do an ultrasound, then I actually utilize a local ultrasound facility called Advanced Sonograms of Alaska. And I've known them for a very long time. And when I did my ultrasound training in Monterey, I came back obviously to Anchorage, and they guided me and supported me in my skills and advancement. And then when I brought ultrasound into my office, I wasn't going into their facility so much to do procedures, but we now rely on each other. So I go into their office when someone in the community has requested, an SIS or an ExEm tubal patency test. And vice versa. If I'm going to be out of town, I don't even second guess sending my clients to them, because they're very skilled at what they do, and they're very reliable. And again, it comes back to that like continuity of care, like I would trust these, I would like the physician I refer to for surgery or surgical interventions, I would have no qualm going to see that person. Right. And the same, like the sonographers have actually scanned me when I was going through my, own pregnancies and things. So, but yeah, just to go back to the topic at hand, I do see more clients in person, but there is always an option for that telemedicine. So I'm so glad we have it.
Hmm. And one thing for patients to really realize is when you come to a fertility center, it's not just the physician you're seeing, it's
Hmm.
everybody.
It's a team
Because
effort for sure.
it's very much a team effort. I mean, you can't go through an IVF cycle without multiple different professionals from
Yeah,
different areas. And so you're trusting your doc to plan things, but you're also trusting them to know who's good that they're willing to work with, because
hmm,
that plays a huge role in things as well.
So, as some of our listeners know, we are writing a book all about IVF, and we actually have a chapter almost completely dedicated to all the people who are on the team. It's
exactly.
that important of a subject. Is that yes, you do want to have a fabulous, leader of your team, but they are nothing without the other people working with
That's
them,
right.
because it really does take a village, and our village is very, very important.
Yes. And it's probably more of a small town than a village by the time we get to the end. There's a lot. All right. So, thinking about more of some of these logistics to get to the topic at hand of how do you how do you plan all these tests? How do you do everything when you do have to bring someone in? Um, how do you do all that imaging? You mentioned you work with another center that's close to you and bring people in there, but you also go in to do your saline ultrasounds and some of the tubal testing. Like, how does that work? What do you like to do? What do you like to use? All of that.
So if I am here, like the only time I wouldn't be doing a procedure if I was not in town, and it's rare, but it happens. And that's when I'm referring over to another facility to do my scans. So I'm doing in-house all of my follicular studies, and I'm doing all my saline ultrasounds. And then we have now for, I want to say years, done the ExEm Foam tubal patency testing. And I was originally, when I didn't have ultrasound in the office yet and was doing procedures at the ultrasound facility, we were doing ExEm there. And it was the first time I had been exposed to it, because traditionally we're sending individuals for their HSG in radiology, and that can be done here. It's done at one of the imaging facilities or at the hospital imaging facility. But my first take on it was we were going to get these samples and let's try it out and see how it works. We, heard about this tubal patency testing with ultrasound. And so we started doing them, and we're seeing really good results. And, I guess for listeners, when we're talking about the, like saline ultrasound, tubal patency tests, when I'm talking to my clients about doing a saline ultrasound, I often talk about wanting to know, is the uterus a good host for pregnancy? And so I use an analogy of, if you imagine like a balloon that's not blown up, and the cervix is where you blow in, and the neck of the balloon is the cervical canal, and the balloon itself is the uterus. When it's not blown up, we can't see what's going on in it. We put a little fluid in it, like saline, we're able to look at the lining and see, are there adhesions or scar tissues or polyps, which are like skin tags. And, that gives them a good idea of like, okay, yeah, that's what we're looking at, that visual. And then I often talk about, and at the same time, we can assess to see if your fallopian tubes are open. We want those open because we want to know that the egg is going to meet the sperm in the fallopian tube and fertilize and then travel down to the uterus to implant. And so we have this, the ExEm, which, is similar to a saline, but it's a solution that lights up on ultrasound. That's kind of how I explain it in my office. And, we're able to look without radiation to see if your fallopian tubes are open. For me, it's again, access. I can do this procedure in my office. And I guess the number one thing would not necessarily be access, but it would be comfort. Knowing that I'm doing this procedure, that I'm doing them often. I'm not having to, go through all the whole solution or, overfill the uterine cavity. I'm able to get the imaging that I need as the provider to say, yes, this uterus looks very healthy. These tubes are open. And I point to my, clients. I say, look, here's your fallopian tube.
Yeah.
And they're often very interested, in that. And, it's really empowering for them to know what the care is that they're getting and receiving and seeing that firsthand. So doing those procedures for me in-house it's just really important. I learn a lot about my client's anatomy. We're able to talk through it. I often say, it's gonna take me longer to set up for this procedure than it is to even do it. No need to put their feet up yet. Like I have to move all these things. And So yeah, I would say like patient comfort is huge. You know, again, some individuals are coming in and they have some past trauma, and you know, you want somebody that you're comfortable with doing a pelvic exam and you know, doing these procedures. And we don't often know when we're sending folks off, you know, what they're receiving.
So what percentage of the time would you say that you can see tubes with the test versus, because for an HSG, I think if I'm really worried about tubes, sometimes I'll get an HSG just because I'm more convinced that I can see it sometimes with an HSG as opposed to just with a saline sonogram. So how with ExEm Foam, do you think seeing the tubes is a lot easier? Or are there many times that you have to actually refer them then for an HSG because you can't see their tubes, or is that pretty unusual?
So I have referred 2 people over, and it was very early on. So I've done hundreds of these procedures with ExEm, and I've sent 2 people
Huh.
over, and they were, one had a blocked tube and it was confirmed with the HSG, and the other the anatomy, it was really hard to see one of the tubes, and so I sent them for an HSG, and they had bilateral tubal patency, so 2. And you know, and that says a lot about the product.
That's impressive. Yeah.
Yeah. So, and I love it. When I was at PCRS this last year, I had brought my medical assistant with me, and I was like, "Oh my gosh, you got to come, come meet these ladies with ExEm," and just, I love the product. And yeah, and and clients, I've had clients who've had previous, HSGs, and maybe we do a saline ultrasound because they've already had their HSG. And I've had them say, gosh, I wish you had been able to do my HSG,
Yeah.
So
Yeah.
a couple of questions with when doing the ExEm foam. So I think as practitioners, we all recognize that saline ultrasounds are usually better tolerated than a traditional HSG.
Mhm.
Whether it's because of the balloon or there's more irritation because of the radio-opaque dye or whatever it is, how much discomfort, like where, if you put on a 0 to 10 scale, and granted, some people with HSGs don't feel anything, some people
Yeah.
feel a lot, okay? Let's say the average person feels like a 6 on the HSG pain scale, the average person with a saline ultrasound has like a 1.5. Where would you put the ExEm foam technique?
Closer to that 1.5 for sure. And I think I would say that it also, you have to take into consideration the, amount of like cervical manipulation that may or may not be happening before. Because
Yeah.
I don't use a tenaculum. And unless I have to use a tenaculum, so I don't use a tenaculum, which decreases the discomfort greatly.
Yeah.
And then I place just the minimal amount. And with the ExEm, you're able to see it, kind of glow into the cavity, the uterine cavity. And sometimes it just takes a waiting, right? Waiting. We're all very, we want things to happen. We want it to happen now. And sometimes even when I've gone over to the ultrasound facility and done them, I just tell the sonographer, they're helping doing the images. And I'm like, we're just going to wait a little bit, and with time, you see that, the spill happen. And it's just, kind of waiting, and instead of, just plunging more fluid into the cavity, but just being patient that, we're gonna see it, or we're not gonna see that, spill.
But you're saying you don't have to put a ton of
let the spasm release in case it is.
Yeah, you don't have to push a bunch of fluid.
Yeah. And sometimes I might just use like 5 cc's of the solution. And the same, with the saline ultrasound, it doesn't take much to get that good image. And that's how I was, I was trained, to do the saline ultrasounds, bedside. And but yeah, I would definitely say the comfort is much better. I would describe it not necessarily like pain, but more clients saying that they feel a lot of pressure more than they do, discomfort.
Yeah.
During the procedure.
What are the ingredients of the foam? Like, what does it do afterwards? Because that's very different than the saline that we push in and other more fluid materials that just get reabsorbed relatively quickly. What's the actual foam made out of?
Right. So it's an air polymer. So the first ingredients, you'll have to bear with me because I'm looking at my notes here. And
how long do they stick around within the body?
So the ExEm itself, I often will tell clients like, okay, you're going to feel like you're leaking because you are. And
yeah, what goes in has to come out one way or another.
That will slowly, you'll slowly leak out. Gosh, I should have been a little bit more prepared with,
All right. It's okay. It's okay.
Yeah.
Who are not good candidates for this? Like,
that's a good question.
Who are people who you're like, this is probably not going to be the best option. You probably need to do a conventional HSG.
I would say individuals that have high risks. Like if somebody has come in and they've had, if I'm suspecting that they might have like Asherman's, then, I'm more focused on that uterine cavity aspect. And I don't necessarily, want to put them through more than anything. So I would say that they would probably be a good candidate for that. Although I'd probably start with a saline ultrasound to assess that. I think anybody is a really good candidate.
Any concerns about BMI or other health conditions or anything like that?
I guess you would, depending on, what your clinic, if you have clinic protocols that you stick to, but I personally feel like, the ideal patient, doesn't have acute, illness going on, like they, aren't experiencing a UTI or a vaginal, infection. Of course, and having a negative pregnancy test, obviously we're not doing this on pregnant individuals. And then, we're looking at where they're at in their menstrual cycle to be able to do the procedure. Also not having somebody who's not like actively on their cycle, and bleeding.
So for heavier patients though, does it make a difference? Can you see just as well if patients are real heavy, or is there kind of a limit?
I've had clients that have, BMI 40 or over that we've been able to clearly see, that they have tubal, bilateral tubal patency, or, if they have a block, we're able to see it. I think just that access to being able to, have good imaging done, body habitus can play a role in not being able to see things. But in my practice, I haven't come across that at all.
If you've got someone who you have a higher suspicion that they're going to have a hydro or hydrosalpinx, so fluid filled tube, is this something where you would do this on them, or you would just send them for the HSG?
I think I would still do the ExEm, but I'd probably do it where I know I would probably have, instead of doing it in my office, I would have a second hand with me to be able to capture more of the imaging that we would do in more of like a diagnostic pelvic ultrasound. And then
just to make sure you capture the imaging of the hydrosalpinx itself.
Right. Yeah. Yep. Yeah.
how long does the image last on the screen? I mean, is it just like with the HSG, it just kind of flitters away after,
No, you can
long?
actually like can watch the spillage continue to happen through the tube. I mean, we're not necessarily sitting there for, minutes. It is,
Right.
going to dissipate. But it's always nice to catch a cine clip so that you can go back and, actually see that that's happening. But I find it really phenomenal, and being able to like point to the screen and show clients like, this is your fallopian tube and you can see the
Yeah,
fluid
that's pretty cool.
flowing
Yeah.
through it
Right.
is pretty amazing.
That's
Mhm.
neat.
So did you happen to find any of the information of how long it lasts, like how long it takes to get reabsorbed into the body, if there's any long-term effects? Because of course we're always super paranoid about everything that we put in there. And the
Right.
radiopaque diet HSGs has a long record. The saline ultrasound for hycoses, that's easy. But how about the foam? Because
Yes.
whenever we do polymers, I think things that tend to last longer. And so I'm just curious of what kind of breakdown it has and half-life and
Right,
all of that.
right, exactly. So it is, a water base, and what happens when the polymer is activated is through the mixing process. Um, I don't have I don't have the information on like how long
Sure.
it stays. Um, I'm just looking back through what Geraldine had actually sent me. Um, and
So
I'm not.
anything else that you'd like to tell us about the ExEm foam and that type of thing as we kind of wrap up today?
Yes, I would share that I will continue to use it in my practice, and a big part of that is client comfort, and accessibility. Also knowing that, no one's getting exposed to any radiation while they're going through
Yeah.
the procedure,
I
as
just
well.
thought of one more thing. How well is this something that if somebody has diagnostic coverage that their insurance usually pays for?
It's a good question.
That is a
Question.
great question, and not right now. They do not have coverage because there's not a CPT code tied
Oh,
to it.
Okay. So
So,
you don't even code it like a saline ultrasound. It's its own thing. So it's just
right.
a service.
Yes. Yep. Exactly. So it is FDA approved. And from my knowledge, they are working on getting a CPT code tied
mhm.
to it so that there can be coverage. It's fairly inexpensive when it comes to purchasing it. And clients can actually like go on to the ExEm website, and find out more, about it and what it does cost. So I think too, like as a service, that's being offered, that your provider is able to do in-house. I think it's something that, being that it is a low cost, that it should continue to be that way for, clients until coverage, can be, till insurance can be billed.
Yeah, it definitely is a process with all of our new
Yeah.
procedures and things that get developed in an emerging field like fertility. It's
Yeah,
exciting to see new
definitely.
things that are available, but there always does seem to be a lag between what we can do and what necessarily the coverage that ideally more and more people are getting.
Yeah. And I just, I wonder if, I would say that it's, just to go back to like what it's based out of, I'm like having this epiphany now. It's a glycerol and water, purified water. And
Okay.
so it's like mixed together, it makes all these little air bubbles that are formed into, this foam. So one of the gals explained it to me once as, you know, when you're in a bubble bath, you can like run your hand through the water and you have all that resistance. But if you run your hand through the bubbles, it goes kind of freely. So that's what it's doing within the fallopian tubes.
Good description. I'm glad that you remember. Thank you.
Yeah. Yeah. So, you know, I'm not, and I wish I could remember how long it stays in.
It's all right. It's all right. It's all
But it's
good.
water-based, so it's probably absorbed pretty quickly.
It's water-based, right?
Yeah.
Well, thank you. Thank you so much, Rhianne. We appreciate that you came to talk to us and tell us about this, and your practice is Full Moon Fertility up in Anchorage. And also thank you so much to ExEm Foam for sponsoring this episode, which helps to keep Fertility Docs Uncensored free and accessible to our listeners. So we are grateful for their help in that respect very much. So thank you so much for joining us.
Yeah, thank you for having me.
And to our audience, thank you for listening. Be sure to tune in next week for more. Be sure to subscribe, leave us a review on Apple Podcasts. We'd love to hear from you. We're on Instagram and Facebook, YouTube. So please hop on by and leave us a like or a follow and subscribe and say hello.
And you can also visit us on fertility.uncensored.com to submit specific questions. All questions will be answered on our podcast anonymously for the Ask the Doc segment. So leave us some episode ideas or any other comments.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon. Bye.
Bye.